Everyone, welcome back to another episode of the Scrubbed In Show. I hope you've all been keeping well. This week we have with us another incredible guest. We have with us Dr. Hasnain Abbasi, who is a co-founder of AT Medics, the largest primary care provider in England, who merged with Operose Health a few years ago. They have a collective management of over 650,000 patients. He's also co-founded AT Medics, AT Learning, a primary care director, and involved in digital health transformation. Absolute pleasure having you on the show, Hasnain. How are you?
Welcome to the show.
Yeah, I'm okay. Thanks, guys. And looking forward to it.
Anyone, if they were to kind of Google you, check you out on LinkedIn, they will know the incredible things you've done, the acquisition, AT Medics, how you grew to hundreds of thousands of patients. But what we like to do is we want to take it all the way to the very beginning, kind of the early stages, your motivations to study medicine. I know you went to St. George's, and kind of bring us up to where you are now.
So look, man, I was one of those who had a lot of family pressure to do medicine. I really didn't want to study medicine. I kind of hated undergrad. I hated preclinical medicine, and went to St. George's, obviously. But then when I got into clinical medicine, I really enjoyed it, and really haven't looked back. Obviously, George's was an amazing time because that's where I met all of my partners. We all went to med school together, the people that I ultimately work with. So, it was just destiny. But yeah, I really had no interest to do medicine. I was pretty strong at maths. That's what I wanted to do. But like Asian parents,
very
keen to do medicine. So that's kind of the story. I was pretty average student. Wasn't anywhere near the top. Just kind of scraped through at each stage. So I'm just lucky to get through, really.
So straight off the bat, it's important. What would you have done otherwise? You said you studied math. You would have studied maths. What career path would you have taken if you didn't do medicine?
Yeah, so look, I really wanted to do engineering. So I was really strong at math, physics. I wanted to do engineering from but it was kind of like, my dad had said, me and my brother, who's also a radiologist, it was like, you both got to be doctors. And that was it. He just said it like a million times. So it wasn't really an option. It was like, okay, where do you want me to apply? Like, filling out my UCAS form. So that's how it was.
It ended up working super well for you guys. I imagine they were friends first before they became co-founders. And tell us about that relationship. And did you know you guys would go off to do something? Or, how did you meet? What was the vibes like?
Yeah, I mean, look, man, we were just, bunch of guys came from different parts of London. We didn't know each other beforehand.
Okay.
And we just kind of got into a group, became very good friends. Some of the guys that had come from further afield were living together in a flat. And we were just good friends, really. We had no idea we'd ever go into business together. There was no plan. Even after med school, we remained in contact, but people went off to do different things. So Tariq, who's one of our partners, he went off to do pediatrics. I went off to do anesthetics. Manib joined the RAF. So people went to do different things. Some people went straight into GP. But even at that point, at the beginning, there really was no master plan, as it were. We had at university, we're going to do something together. Some of these things are just luck and timing. So at that time, it was just really good friends, very, very good friends.
Hasnain, walk us through, though, the process of self-discovery. So you've gone through med school. You've obviously said that you haven't enjoyed it much, but how does someone like you transition into what it is right now? Talk us through that journey.
So look, what happened is medicine became interesting around year 4-5. That was like a time where I was like, oh, thank God I did medicine. This is an amazing career. I really enjoy it. I thank my dad. It was a good choice. We then all kind of came out of med school. And really Imran, who's one of our partners, it was his original idea. And his idea was, guys, let's work together. It's so much fun. Like, we all get on. Why don't we try and work together? Why don't we all do general practice?
Yeah.
And then the idea was to try and work together in one single GP practice. But it was obviously a silly idea, because how do you get 6 guys into like a single GP? Then most practices were much smaller. So once we'd kind of decided we wanted to do something, and we weren't entirely clear. I mean, that's, I suppose, one of the other learnings for other people, that we weren't entirely sure where we're going to end up. We just had a general sense. 2 of our partners, Imran and Osman, they qualified first as GPs. And really at that time, the idea was, okay, what we're going to do? So I swapped out of anesthetics into general practice. Tariq left pediatrics. Manib kind of left the RAF. And we kind of started to decide, okay, well, if we can't work in a single practice, we need to start to think about how we're going to make, how can we get into this sphere of primary care? and it sounds crazy now, man, but this is like 2004-5. We had a book where we had all the primary care directors in London. We just wrote them. Sounds like so silly now. We wrote them a letter, like handwritten letter.
Oh wow.
We posted it, and no one responded, but one guy responded. It's always a story. One guy responded in West London, and he said, "Look, I've got this GP practice, but the GP is about to be struck off,
Oh.
and I need someone to take over the practice." The practice was one room. That's it. It was like one room. You walk in the door and a really tiny room on the side for reception. So we were hungry, man. We were like, cool. So Imran Osman took over that practice.
Okay.
And started to turn it around. At the same time, this was as a GP registrar now. So we had a practice had come out. Again, unfortunately, where a GP had suddenly just died. And the PCT were looking for someone to take over. So we kind of put in a really rudimentary bid. And, I remember typing in how to write a business plan. Like, we didn't know what to do. So typed it in, wrote up a rudimentary plan about how we might run this practice. Anyway, they gave it to us. And so those were our first two practices. And we just learned on the job.
Just for kind of course of the viewers and the listeners, what does it mean to run a practice? Because traditionally it's GP, you're salaried, you hear the word partner, you don't really know what it means. Yeah. What's the difference of being GP and running a practice?
So look, being a GP partner is quite unique within the NHS because you take the risk of running that practice. So the way it works in your practice is you will get £1 per patient, you get some money for managing a population. Now, within that budget, you have to pay the staff, pay the doctors, pay the bills, do all of that kind of stuff. And whatever's left at the end is your profit effectively. That's your income for that year. And whether you're a 1-partner practice or a 5-partner practice, it kind of works like that. So you can imagine those practices are very well run. They hit all their targets because that's the way GPs are paid. It's incentivized according to targets. You have a big list size. You're going to earn well. You're going to do well. Those practices that are, quote unquote, badly run, or they might be in a really deprived area where, there's a lot of demand. They might struggle to make, and that's where you get disparities in income. When you're a salaried GP, it's a bit like, I suppose, when you work in a hospital, you do your job, you get paid for it, you get paid every month, you know what you're getting every month. Whether the practice does well or badly, you are into a contract. Now, if you look at it now, unfortunately, the way primary care is developed is that a lot of GPs are going into either into locuming or salaried, or there aren't as many partnerships around. So it has created a slightly, definitely a 2-tier system where you've got partners and salaried GPs, and that's been an issue. But that's the kind of the broad difference between the two.
Interesting. Thank you for sharing that. And kind of going back, so you had these two practices, which you're now effectively running. You're kind of learning on the job. Yeah. Tell us kind of a bit more how it grew, how it all kind of, the next few things that happened afterwards.
So look, we took over this practice and we didn't know anything, genuinely. Yeah. So the first thing is sometimes you learn by doing. So we got in and we were like, oh, damn, like we actually employ. I remember the night before, I thought, God, man, we like employ 5 people. Like now we're responsible for making sure 5 people get paid on time. So I remember, at the end of the month, logging on, paying people their pay.
Oh, wow.
Making sure people's pensions. So I learned how pensions were paid for staff. I learned how payroll was done. The practice we went into was completely mashed. So we kind of, learned about how to set the waiting room up. It had no IT in it at all. So we kind of learned all of the aspects of running it on the job. It was like business training you can get. At the same time, we were consulting. So we were working like full-time as clinicians. Oh, and wow. This was like on the side. And Imran and Ozzy were doing the same. They were kind of, digitizing notes, bringing that practice up to speed and learning the same journey. So we all kind of went on this journey together to learn how and what is efficient. What's a good way of running primary care? So after those two, and then, luck plays. So then what happened around that time, man, is that there was a general feeling that Labour wanted to open the market of primary care up to other providers, yeah? We call them private providers. We were obviously GPs, but we set ourselves up as a company to begin with. So we didn't go down a traditional partnership. We said we're going to behave like a corporate entity, even though we were tiny. We had we were earning less than all of our friends that had gone into jobs. We were, earning probably half what they were earning. But we wanted to set ourselves up in that kind of corporate. And then what happened is that PCTs, the people that run, local health outside of hospitals who commission contracts, they started putting contracts out for GP practices. Some were new practice, some were practices that had been really run into the ground. For whatever reason, someone died or they were just badly run. So we then wrote a bid. And at that time, I mean, you guys are really young, man, but at the time, people were trying to come into the market. So United Health were a massive American corporation. They came in and started to bid. We were bidding, but there weren't that many providers. So obviously we were clinicians. And so when we wrote our bid was pretty sick, because our bid, we really analyzed the health needs. We knew how to run a good practice. And this was actually in Trowbridge. So Trowbridge is in Hackney. So it was the first practice we properly did a tender for and we bid for. And actually we won. So we beat all these big providers. I remember going to the interview. There was two of us, United Health Europe, about 8 people turned up with like case, that and the other. And we were just two of us. And anyway, alhamdulillah, we got that practice. And so that gave us a lot of confidence that actually, we kind of know what we're doing. We're not 100%, but we kind of know we're in the right ballpark. Again, it was a very small practice. We then kind of bid for another. So, the other good thing about Luck is that there weren't that many GPs doing what we were doing at the time.
Mm-hmm.
So, it was a bit of a virtual territory. We were going up against big corporations who didn't really understand primary care. That's one of the things we've learned over time, that it's a very detailed area and a lot of people don't understand how it works. So we basically went on from there, man. We bid for 1 practice, 2 practice, bid for a few more. And before we knew it, we were up to about 5 or 6 practices, mainly in like Lambeth, some in Croydon, and a couple dotted around. And so that's kind of the kernel of where we were like, okay, this is now a multi-site organization we're running.
Amazing.
Before we kind of move on, tell us what it means when you put in a bid. Is the bid kind of like a proposal, we're going to do X, Y, Z, or is it we want to buy this practice? What does that bid mean?
Yeah, good question, man. So look, these are public procurement. So these are tenders that are put out. At that time, this is pre-Brexit. They were Europe-wide. They were advertised Europe-wide. You have to put in a bid. And it's changed over time. That's the other thing. But in the very early days, we would just write a business plan. It might be like a 50, 100-page business plan covering governance, prescribing, complaint handling. And over time, CCUs learned how to make this more professional. So now what happens, man, is it's very, very hard. They basically publish a tender document.
Yeah.
And you have to sit there writing out answers effectively, like short answer questions, 500 words, 1,000 words. How are you going to manage? What are the health needs of this area? And how are you going to manage it? That's one question, for example. Another question might be, how are you going to assure us that your clinical governance, what's your clinical governance system? One might be, how are you going to ensure prescribing is good? And you can imagine there are like maybe 50 questions. Plus you've got to put in a financial proposal about how you're going to run the practice. So you don't buy them. These are tenders that are put out. So there's no upfront capital investment other than your time. You've got to sit there and write them out. It's the most painful thing I've ever done in my life, and I probably ever will do. It's so boring. It's so hard. But what we learned is that, our win rate, I'll say it because just going through, but our win rate at the end was like over 90%, which is just unheard of. Why?
Wow.
Because you had 6 clinicians plus some very highly skilled non-clinicians that have been with us for a long time. We just knew what to write. And so when you mix that clinical plus business mix, I personally believe it's unassailable. I think it really puts you up at a very high level.
I want to ask an important question, because you're probably the first person to come onto our podcast with a co-foundership of more than 3 people. With regards to your team size, talk to us a little bit about the dynamics. How did you guys split the roles? How did you guys work with each other? Because there will be some startup founders listening to us who have bigger teams, and everyone will say, we only like teams of 2, teams of 3. How does it work with the team of 6? How did you guys manage that to such a successful point?
It's a great question. It's one we get asked quite a lot, man, because it is a bit unique to have 6 people come together. The first is just trust. You have to have unbelievable level of trust. If I give you a small anecdote, one of the things I've often seen partnerships, even a 2-man partnership break down, is often over money. Like people start to get upset about taking what, even GP partnerships, I've seen much smaller ones. I've got to tell you, man, right up until, we merged, we had 1 signatory on the account. Like our bank used to tear their hair out. Like they say, you got to have 2 signatories. And we had unlimited, we had no issue with someone might take 1p more than the other. We never had an issue. So one was unbelievable trust. I do think faith plays an important part of that. Yeah. So, as Muslims, we have a very strong belief in honesty and fairness, and being fair to other people. Whether they're Muslim or not is irrelevant, but just that sense of fairness. So that made a big difference. That we had a common faith, and the level of trust was very high. Your question about dynamics is an interesting one. So we had very different personalities. So one of my partners, Imran, for example, amazing visionary. Even now I would say, if someone sit down and talk to him about what's going to happen in 5 years, it's like the guy's got a crystal ball. Amazing visionary. We
Amazing.
had, one of our partners, Tarek, was very strong in data analytics, and he actually amongst us was a prize winner. So he won University of London honors. He won all the prizes. So very, very smart. We had, all individual. I won't name each of them, but Ozzy, I'll name one more. Fiaz, everyone had some individual skills just by luck, man, that fitted together like a jigsaw. But I would still say, man, ultimately, you have to trust each other because you have to trust that the other person is working hard. What do people break up over? They work because they think they're working harder than someone else. They think they're not earning enough. They don't think the person's putting the effort. The other thing that make co-founders, I do think 6 is a big size, though. It is a big size.
Yeah.
And we used to have massive rows, like crazy, like arguments and fights. And we'd often say, like, this can't be the way. But then I realized later, man, that shows passion, shows you care. I'll contrast that with one other thing. So many years later, I was on a governing body for a particular CCG. There were never any arguments. Like, no one ever argued. And I found it so strange because I'd go back to ours and we'd be like, to fight each other, over what we should do. But I learned that actually, when it's your own money, it's your own business, the passion, that's what makes you want to like make it right.
Absolutely.
When you get people that are, it's their job. This was more than a job. This was like our life of work we did every single day. But 6 is big.
So Hasnain, if you can give us an example of, say, where you've had a bit of a discrepancy, those rows you've explained, how did you guys go about making a decision then? 6 of you guys, let's say 3 and 3, how did you guys make that big decision? What's the framework you applied?
Yeah, listen, man, there was no academic theory to this. What we did is we were all, so the way it grew, the way the business grew is that we were in geographic areas. So we were like, look, we need to take over certain areas into regions. And so if we had a disagreement, we would say, okay, look, let's test it out. You test your model over here. We're going to test our model over here, real life tests. And let's evaluate and let's see where we end up with what's right. And that ended up being a really powerful thing for us to learn. Even recently, in the last few years when we launched our online consultation platform, Dr. IQ, we don't do it the same across the business. We couldn't agree. So we had a long argument about how we should run it. Should it be GP-led? Should it be AHP? Should it be a hub or not? Whatever. And so we're currently just evaluating which model we're gonna go with company-wide. Because sometimes you don't know. You want to try it. Yeah. So we always had, one of the things that we always had in our business was, don't be scared to try stuff. Try it. Even if you screw it up, doesn't matter. At least you tried it and you learned. So we had this kind of spirit of, let's try it in real life. So we're big on practical. How can we run it? How can we do it? And that worked really well for us, man. Really, really well.
I feel like there's a sense of kind of brotherhood, trust amongst your co-founders, the willing to experiment and that passion, that grit, to make it work. The question is, you're kind of at this stage now, you're running 5 or 6 practices. At this point, did you have like a playbook? You put in a bid, you go in, what are the first few things you do to a practice? Do you kind of get rid of everyone? Do you bring some talent in? What was the playbook, or did you not have a playbook at this point?
No, I mean, the practice that we were taking over were absolutely mashed. That's the first thing to say. These weren't like high performing. That's why they were all inner city areas. So we're talking about, even if you look at where our practices are now, they're in like Tower Hamlets, East London, massive Bengali population, quite deprived. We've got another one down in Croydon, but I'm talking about, the really deprived outer areas. So all of our practices were like that. So we kind of understood that. I mean, look, it sounds a bit holier than thou, but because all of us were from very, very humble backgrounds, we had a very strong passion for making sure we give good quality care. That was like unbelievable. It was like, we have to make sure we never compromise on it. And that's got to be our USP over everybody else, that no one should be able to touch the quality of the care that we provide. So we learned quickly, when you go into a practice, what are the key things you need to do. So, all the high risk safety stuff, who are the high risk patients, child safeguarding, what are the big governance issues? Are there any issues around like data security, data protection? You're absolutely right, man. In the end, when you get bigger, you rely on other people to deliver whatever you're doing. Particularly, health is a service-based industry, right? So getting good doctors in the beginning was less of an issue because we were consulting like mad. Like, we used to consult crazy sessions all the time, But then as we got bigger, obviously you can't do that. You get, diminishing returns, right? We found some really good gems. One of the things we learned, man, you can't go into a practice and get rid of people. It doesn't work like that. Yeah, employment law, and we learned that over time. We learned, how do you manage people? How do you manage people in? How do you manage people out? How do you make sure you've got the right staff doing the right things? It's actually, as you scale up, it becomes more challenging. Yeah. What we did do though, man, is very careful not to expand too quickly. So we expanded to about 6 practices, and we learned how to manage 6. Then we were like, okay, then we expanded probably up to about 9 or 10. And then I think when we got to about 12, we stopped. For a long time, we stopped. We said, look, we don't want to bid for any more until we're sure we can deliver very, very good care to our practice. There were other GP groups, that came after us and overtook us. Yeah. So our trajectory was much slower. They came, they bid. When we had 10, they probably had like 15. Yeah. And they kept bidding. And we were like, no, we're going to only grow in a managed way, because healthcare, it's not like we're not, we're not selling chips, fish and chips. We've got to make sure. If you look at it ultimately over time, man, we then ended up taking over those providers' practices because they just couldn't do a good job. They just couldn't run those practices. They just weren't set up, because you're not running, it's not favorite fried chicken. You've got to have understanding of nuance, of culture. You can't run the practice in Tower Hamlets, where we had 85% Bengali patients, with the way you run the practice in New Addington, where you got 85% white patients who are from lower social working class. You have to understand that, right? And so we were lucky that we kind of understood those differences. And so ultimately, man, we if you want to take it like that, but we grew much larger than all our competitors, because it was much more managed, much more careful, much more detailed, really understanding the detail. And that's what I'd say to people. You really need to understand your area, your subject matter. So when you're in a room with people, and it's your area, you should be the smartest person in that. You really got to know it inside out.
Absolutely.
Tell us a bit more about the tipping point where you're onto something, where it's like, all right, like we've doubled down, you're not doing any more clinical work, you're just kind of managing executive. What number of GP practices was that point where you just kind of, it just shot up?
Yeah, so I think once we got beyond sort of 10, then we were like, okay, this is a size where we think we can just replicate what we do now. There's a critical mass we've got. Once you get to 50 to 60,000 patients, you have enough critical mass where you're going to need some corporate support. You then start to centralize. So we centralized all our back office functions. We had an HR department, a finance department, all of that kind of stuff. I think at that time, man, we probably had 80 to 100,000, but 50 is probably the point. If you ask me a number, 80, 100. After that, we were like, okay, we kind of know how this works now. We've got a model, a really set model of how it works. And then the other thing that probably, there are some other things along the way, but maybe I'll touch on now. So one of the big problems in primary care, I'd even say in secondary care, is understanding of data and everyone agreeing one version of the truth. What is the current data? What does it mean? And so when we had probably about 6 practices, we'd have one person literally making Excel spreadsheets that we'd look at and say, okay, your blood pressure control is poor, this is not very good. So we did a project with the data. We did something called the Knowledge Transfer Program. It's like a research program with University of Surrey to develop our own analytics tool. We said, can we develop our own analytics tool that sucks up data from our practices and presents it to us so we could just look at it and say, okay, this is what's like a dashboard. And so really, man, that was a really big turning point for us to understand really what is happening in the practices, understanding what the data says. I know now it's more commonplace, but at the time, this was really way advanced, and no one was really doing this in primary care, to have one set of data which is so rich and deep. That eventually became a product called Easy Analytics, which now is a core part of our offering. We use it in our business. It's also been sold externally to CCGs, to PCNs, to other GP practices, who are able to look at the data and interpret what's kind of going on. So that was an important milestone. I'll say one other thing, and I'll be quiet after that. I suppose the other bit that we realized, man, probably in about 2017, 18, we kind of realized that if we don't have a tech offering ourselves, then we'll be dead in the water. And so in 2018, we created a new company called AT Tech. We partnered with one of our friends called Hasib, who had worked in the CCG, had a lot of knowledge of NHS IT. So we set up our own technology company with our own developers, offshore and onshore. So offshore, we set up a whole organization in Pakistan. We had about 70 developers working. We had a whole team there. We had a team here as well. And that really developed the analytics tool. And we developed our own online consultation platform called Dr. IQ. That was a really important part for us. And then with Umar, who ultimately is now our MD and became our CEO, we developed a learning platform, which was teaching allied health professionals, nurses, GP registrars, physician associates, clinical pharmacists. We developed our own learning management system for them, because that's what you need ultimately. You need good quality training, you need technology, and then you need the primary care. And those three together made us a really unique proposition because we controlled all those bits of it.
That's very interesting. And I think it shows that even from an entrepreneurial point of view, opportunities, problems, solving it, you just stick to kind of the 18 minutes and kind of building that out. Tell us a bit more. So you're on this trajectory, you're just accumulating, taking ownership of more and more practices, building it up, hundreds of thousands of patients, looking after them. You're definitely doing a good job. Tell us towards the end phase of that journey when it's coming to acquisition. Was that on the map? Did you think about it? How did that offer come about? What was the process? Tell us about that half of the story.
Yeah. So look, I think the first thing to say is that we were getting to a good state of maturity from a tech perspective and the learning. So we had a good methodology, because just to take a step back for answer that question, if you look at what are the big problems, any founder needs to solve a problem that people really have. So the problem in primary care right now is workforce crisis. Been around forever, yeah. Everyone, even since when I was GP, there was like never anyone around. So workforce crisis was a big problem. Tech in the NHS, as you guys will know, is very poor in general. It's very hard to penetrate. It's very hard to actually make it work and for people to adopt it. Being just in primary care helped us. So one of the things we did, we only focused on primary care. We never went away from our mission. So we never went into secondary care. We never went into community care. It was just one track. So we really focused on one area, and everything then. So all the learning, the teaching, the education, the technology was all focused into becoming that one area. The other thing we did, really out of laziness, was never been outside London. So we're all from London, yeah. We never went to Birmingham, never went anywhere else. And if you look at other providers, they were dotted all around. And we used to always think, God, like, how do you manage a small practice out here and one out here? We were all in London, yeah. So I could get to any of our practices within an hour if I had to.
I see.
Yeah? All of us could. So we were nice and neat. So at this point, man, we probably had 370,000 patients. So that whole group, so we call it AT group, but that group of three organizations was quite powerful. I mean, look, it wasn't on our roadmap, is the first thing. So our plan was just to keep running it. There's no reason to not do anything. We never solicited it. We didn't approach. From time to time, we'd get like spam emails saying, are you interested? We've got like, people want to, are you interested in having a discussion? We weren't really particularly interested at that point. We had a chance meeting, actually. Our CEO at the time had a chance meeting with the CEO of Operose Health. It was a group of, I think it was for female CEOs in healthcare. There was a meeting where they met, and there was a discussion about coming down to meet us. And for one reason or another, man, we didn't meet them probably for about 9 months, because we went into a tender process. Because they were our competitors, we didn't want to get done with collusions. We said, look, we can't meet you right now. We can't talk to you right now. And then interviews and so on. I think it probably took about 9 months. They kind of just said, look, we're just want to come down and see what you guys are doing. We were like, yeah, no problem. We often had people come to visit us to understand what we're doing with tech. So we said, yeah, no problem. And then they kind of met us, and then nothing really happened for a little while. We just kind of carried on. It was not an issue. And then there was a discussion around, look, how would it look if there was, would you be interested in looking at a merger? Now, what I'd say diplomatically on this podcast is we were 6 guys in London. When you get bigger, you get noticed. Yeah. So when you have one practice, nobody cares. But if you've got like, I don't know, man, I think at the point of takeoff, we had like maybe say 35 practices. I can't remember, don't know what the number was. Yeah. You're not always flavor of the month. And you need a bit of political cover. You need a bit of cover from someone to make it, at a high level. We were always a bit disappointed, man, that I've never really said this before, but we were always a bit disappointed about how the hierarchy in the NHS engaged with us. At the point of sale, man, 1 in every 18 Londoner was registered with one of our practices. That's a big number for a big city. And we used to often joke that, we should be like Harry and William. We should never travel in the same car because, if we had a car crash, you'd wipe out primary care in London for a huge number of patients. So we were quite big at that point. And we wanted to do lots of stuff. So, for example, we talked about taking 24-hour care for our patients. We said, why don't we just give us the budget? We'll take over 24/7 care for our patients. We said, give us our budget for IT, because they wouldn't give us the IT budget. So now we're spending like 100K a year from our own money buying people laptops because we wanted to go remote. This is even pre-COVID, yeah? We'd kind of already adopted that model. And so there were a lot of restrictions in what we could and couldn't do. Why? I'll let people think about why that might have transpired like that. But we certainly don't feel we got the engagement. Some people did now say, Andrew Bland, who is now very senior, amazing guy, really supported, was always happy to have a conversation in the chat. But very high up, man, we never really had. And I wonder whether that would have been different, maybe if the organization had been a bit different or had a different footprint. But certainly we didn't have the political connections, man. We kind of were just focused on doing what we're doing. So what you realize that when you get higher up, man, you definitely need that too. And maybe that was a weakness in us. Maybe our weakness was going out and really, pressing the flesh at high levels.
You answered the question I was going to ask. It was, despite the progress, despite the number of practices and the patient populations you were looking after, the press coverage, the online footprint, the exposure didn't seem as much as it is where there are people with like 3 or 4 practices and they're out there kind of shouting. And I want to ask, why did you think that is? And I'm sure there's a multitude of reasons. It might be, the co-founding team, your access to distribution, so on and so forth. And it's very interesting. And my thought was, could you have taken this to the next level if you had those connections, if you had that buy-in and engagement by those hierarchy, and really give it a good go? Because I thought you guys were the right people to do it, but it felt like there was this glass ceiling.
I mean, look, yeah, that's the right word, basically. So there is a glass ceiling. Let me just tell that to anyone out there. There is a glass ceiling. We definitely felt like we hit that glass ceiling. Could we have taken it to the next level? 100% yes. We still, because, it's easy from where we'd got to go the next stage up is easy because you have resources, you have a team, you have knowledge, know-how. We were all into our 40s by this stage. Like, I'm 47 now, but we were like, 42, 43. You're still healthy, you still have the energy. You're very constrained in the NHS. You have to understand that it's not like, starting your, like you guys have got an independent business. You can kind of take it where you want. Highly regulated, highly regulated. The funding is very, very controlled. It's very fragmented. Yeah, it's extremely fragmented across London. Even now, you've got ICBs. They all work in a slightly different way. They have their own agendas, their own ideas. And so, look, man, you recognize at where you hit your glass ceiling. And, there's been a lot more recently come out about NHS and how, there's a discrepancy between the number of people from BAME backgrounds that get a consultant job or not. We didn't feel that because obviously we owned our own business, right? We were we could reasonably do what we wanted to do. It wasn't a problem. But for sure, man, when you deal with external influences, you never know. And, you don't want to say this has happened because of this reason. You don't really want to say that. But now when I think back, I've had a period of time to reflect. I definitely feel like, that was an issue for sure for us. And I wonder how another organization that might have looked a bit different, how they might have been treated if they were the biggest provider in the country. I mean, isn't it amazing that we're the biggest provider in the country now? Yeah. So imagine in 2021, we are the largest primary care provider in the country. And no one from central NHS, central government ever really reached out to us, came and talked to us and said, what you guys doing? Can we replicate it? Can we give you some funding? Try something more innovative?
Yeah.
All of the money that we put in for tech and learning was our own money. Yeah. Every penny we put in, we never took, because of our faith, we didn't want to take any interest from a bank or a loan. We only put our own money back into it, which was good in the end, but it was all our own money. We didn't get any extra funding from anyone or anything. But you wonder if that had been different. That's all. Who knows?
Definitely.
Hasnain, do you think it'd be different now in the current climate in terms of we've got all the media outlets right now, we've got social media and all of that jazz. Would it have been different if you could shout from the mountaintops yourself? What do you think about that?
I mean, look, man, who knows? I mean, at the time, look, we kept winning bids. Yeah. So we became very good at winning bids. The bid process at that time was pretty slick. And, we basically won. I think we bid for like 10 or 15 practices and won every single one in a row. So we became very good at
Amazing.
that. We get to like 2020. We're thinking, what can we do with the business? What can we do with the organization? Have we taken it as far as we can take it? Are we enjoying all of the business bits? Do we want to concentrate more clinically? What do we want to do basically going forward?
Mm-hmm.
We met Sam. Sam Jones was CEO of Operose Health.
Yeah.
And very credible. She'd been a director within the NHS, very senior level. She'd been the CEO of a hospital, of a big trust. She ultimately went on to become Boris Johnson, the first chief operating officer in number 10 Downing Street. So, very high caliber person herself. Professor Nick Harding, he was a CMO. They kind of came down to talk to us. It was a very slow process, man. It was like, what are you guys doing? Same sort of stuff, what you want to ultimately get to. We felt they were quite connected because they've both done very senior jobs centrally in the NHS. They kind of knew. And so really at that time, man, our brain was like, actually, this protects us, our legacy and organization. If we can get some cover, the organization becomes much larger. And really, man, that process started to probably, I'd say around I think 2021 is when we finally did the merger. But probably, the 6 months before that, the discussions ongoing, how might it look? What would our role look like? Because, we've been used to like, no one ever asked us where am I on a Monday at 3 o'clock?
I can imagine.
You do what you want. So for us, it was like discussion with family, discussions like that. But I think ultimately their vision aligned with our vision, which is primary care, technology, central spine. If you look at what's happening, and I don't know both of your backgrounds, but primary care is in a desperate situation across the country.
Yeah.
And really, it's what does the future model of care look like for primary care? And so really, we became more and more aligned as we started to discuss. They started to understand really where we were trying to get to. We kind of understood where they were trying to get to. And it just made sense for us, man. It just made sense for us to have that level of almost like a protection blanket around the organization.
Which comes to my next question, right? Tell us about that's when I discovered AT Medics, the flack, the public uproar in terms of kind of selling. It was described as selling patients to the American system type thing. How did you deal with it? How did you feel after kind of years of hard work? And I'm sure you had issues, in between all of that.
I mean, look, what happened at the time, man, was the first thing to understand is that Operose Health have been in the UK market for a long, long, long time. Almost as long as AT Medics, not quite as long, but for a long time. They were called something else. So the people that we dealt with throughout the whole period were all people like us, man. They were all like from the UK, born and brought up in England. There were no Americans. It was like all normalized in the UK. We very much saw it as a merger of two English, British companies. I do understand the narrative. I'm not naive. I get patients saying, but the ultimate parent owner of Operose Health is this huge corporation in America called Centene. So I do get that narrative. We didn't really look at it like that, man, because, I've never been to the States. Like, I never met those guys coming over. Our contact, even now, on a day-to-day basis with the people in this country. But I do get the narrative. People are worried about privatization. I think the narrative is wrong, though. I don't think the NHS will ever be privatized, in my opinion. I think politically it could never happen. If it happened, it would be a bad thing. So I'm not a proponent of that. I think if you look at privatized systems in the world, generally increases health inequalities. So the UK system does need reform. It can't stay as it is. It has to be changed. But I don't think privatization is the way. And if I had thought that what I was doing was a road to that, we never would have proceed with it, because we fundamentally don't believe in that model.
Tell us a bit more how life changed post merger, what the day-to-day was, what happened to that Monday 3 p.m. Where are you now on the Monday 3 p.m?
I mean, look, I have to say that what happened is an interesting one, because obviously we had 2 HR departments now. We've got 2 finance departments. They had their own executive team. I've got to say, someone, if they did a study, they wouldn't be able to pigeon. We were like 6 of us, and then people would like our CEO, and that was kind of our exec team. We had meetings, obviously had HR and finance, because at the point of merger, man, we employed like 800 people, so it was quite a big.
Wow.
Big. And so when we then came together with them, we formed a new executive team.
Okay.
So the exec team meant that from the 6 of us, 3 of us joined the exec team. They obviously, a few people left from their side. So now there's a combined exec team that is at the top of the organization, that kind of runs the business. my role is primary care director. I mean, look, fair dues to the guys, I have a very free hand. So I've always, for example, led on the online consultation platform that we developed. I continue to kind of lead on that. When we got bigger, we were really running regions in the end. So like my region was Southwark and Tower Hamlets. That's like it's about 100,000 patients, a bit more than that. So I've continued to run that region, almost like a medical director role. But I kind of get involved in ops. I still get involved in clinical work, and all the directors have their own kind of areas in London. And so it is different. There's no doubt, for any founder that is ultimately undergoes an M&A, you have to understand it's not the same. It is different, good and bad. So definitely less pressure for sure. If you ask my friends and family, they'll say you're definitely more chilled than you were towards the end, where it's more difficult because obviously you're living it every single day.
Yeah.
But then, you lose your autonomy. There is a degree of autonomy. Before I could go in and say, hire this person, or let's sort out a pay rise for this person, or whatever it is you want to do. Now it's much more, I guess more normalized, I would say. Our system was abnormal. Now it's more like, let's bring a paper to the board. Let's have a discussion, pros and cons. In the old days, someone would say, guys, I'm going to try this. And we were like, all right.
Go for it.
Carry on.
Imagine.
So it was like, that's how it became. And, our board meetings were Friday, after Jummah, we'd get like fried chicken in from the local chicken shop. And that was our board meeting. That is what we would do. We would just eat fried chicken there or grilled chicken. And we'd discuss what had happened that week and what we wanted to do. So, we recognized that wasn't normal. And so, but, then you move to a much more corporate structure, which is probably more normalized. It's a big organization now, man. It's 650,000 plus patients. It's a big operation.
Definitely. The question I had was the M&A, the merger with AT Medics plus the Teeken learning, or was it just AT Medics?
No. So what we did, man, is when we formed, but when we formed the other two organizations, they were two standalone companies.
Okay, yeah, that's fine.
Under an umbrella called AT Group. So AT Group was the ultimate owner of all three. And so the merger was at the group level.
So the holding.
Yeah, the holding, because, they were so intertwined as three businesses. For the tech, obviously, we had two products in there, but they were so intertwined that really the holding is where it made sense, really.
No, definitely. Tell us what the co-founders who didn't stick around, what they do, or what happened to them.
Oh, no. So all of us have stayed.
I see.
All of us have stayed on, yeah? All of us have stayed. So we're now like, 2.5 years, maybe 2.25 years into it. We're all kind of working pretty much as we were, other than the constraints that I mentioned, which are normalized, but we're still kind of doing our roles as we were, which is managing our regions, day to day, getting involved in the clinical side and all the rest of it. But it's also true that, of course, with one eye on the future, like, what will happen ongoing, what we want to do. Obviously we get offers from people saying, do you want to get involved in this or do a bit of consultancy? We've had some offers from people overseas that are setting up health systems that are interested in various countries that, are looking at setting up their own primary care. One of the things you realize when you go around the world, I mean, you guys obviously must have family. Where are you guys from originally? Where are your parents from?
Bangladesh, both.
So, you realize that there is no primary care system. If you're sick, if you've got heart, you go to a cardiologist, or if there is, the local primary care system is a guy who just did his MBBS and next day he's working as a GP. That's what all GPs, yeah? There's like no respect.
And the day after he becomes an associate professor, right?
Yeah, exactly. You're exactly right, man. But I think governments are realizing, particularly in the Middle East, that, to have a good, strong healthcare system, you have to have. The problems, one of the things I've learned actually is that the problems in healthcare are the same in every country. One is bringing down the unit cost of healthcare.
Yeah.
How do you make it affordable? How do you improve the quality of care? And really the big time bomb is long-term conditions, man. If you look at the prevalence of things like diabetes and stuff, more people will die of diabetic complications than infectious diseases in Bangladesh, Pakistan, India, because that's the issue. So those problems are, and no one solved those problems yet worldwide. There is no solution, no single solution. There's no magic bullet. So really the question is what happens in the future, man.
Yeah. Hasnain, are you allowed to share your vision for the future of what general practice will look like?
It's a good question. I don't know what it looked like, man. But you know, I'll give you a great answer. So someone asked Jeff Bezos, they said, tell us, you're so like, richest man in the world, whatever, what will Amazon look like? And he said something which is true for any walk of life. He said, look, I don't know what it's going to look like, but I can tell you the things that are true. So people will always want choice. Yeah. In 10 years time, no one's going to say, no, I want one product. They're going to want to choose out of 10. They want quick delivery and they want cheap price. So he says in Amazon, we spend all our time working on these three things. How do we offer better choice at the lowest price, fastest delivery? And that's true. So you can read across the healthcare. What will people want? People want high quality care. They want access to care. So one of the big problems worldwide in the UK is access to care. And at a reduced cost. How do we reduce the unit cost of healthcare? The cost of healthcare in this country is, even though it's socialized, is still high. It costs a lot of money, particularly towards the end of life. Our big problems are layer onto that. Workforce is a big problem in this country. It's a disaster that is gonna evolve in front of our eyes going forward. Not enough doctors staying after their foundation year training. Not enough. My brother was telling me yesterday that two of his colleagues that are finishing their radiology training, both moving to the States. We've got 4 GPs in our organization that have worked with us for a very long time. One's going to Australia. One is going with his wife to Sierra Leone for relief work. One is going, 2 are going to Qatar.
Oh, wow.
These are big issues. So you can, if you look at recruitment, you can keep filling in the top, but if you're losing from the bottom, you're never going to win. So workforce will remain a huge issue in primary care particularly. So access to healthcare, I think people will want. Then the question is, how do you then use digital tools to enable that access? How do you make it safe for allied healthcare professionals like pharmacists, like PAs, like physios? How do they work with a consultant GP model? I mean, we're kind of already doing that, yeah? So in our organization, we've been doing it now. So I run a hub in Southwark, for example, where all of our digital transactions, every single online consult for the whole region, which is 60,000 patients, come into a single hub. We've got a centralized admin team that deal with all of that. We've taken it away from the practice level. And we've got a centralized team of clinicians that deal with all of that. They can then book into the practice if they need a face-to-face. That is the way it's got to go, because there just aren't enough doctors. I say to my wife, who's going to take care of us when we're old? Just aren't enough.
It's a worrying thought. Off the back of that, a quick question is, what are your thoughts on kind of the Babylon situation, and what was it like when they were first introduced, right? They're now, last time I checked, their share price was less than £1, right? Where do you think they went wrong? What was it like when they first came onto the scene?
Yeah, it's a good question, man. So look, when Babylon came along the scene, the first thing to say is that, Babylon had a lot of money behind them. And so a bit like Uber, Uber still doesn't make any profit. These companies don't need to make a profit. They have to show growth. And they have to show a concept of a model. So they were throwing lots of money at showing growth. So they did grow very quickly. They weren't really offering primary care as I would class primary care. I would say primary care is any patient. You come in and say, you know what, we can't take you. We're not taking you. Everyone. And if you look at us, man, we took everyone. In fact, we took the patients that were the hardest patients. With all due respect, Asian patients are the most difficult patients to take on. Yeah, you know what our Bengali uncles are like, and it's like Lambert. We got the Pakistani aunties. These are tough patients. We take them all on. Okay. The second thing with them is that primary care, man, is a very difficult place to actually turn a profit from. And most big organizations have not been able to do that because it's a detailed business. It's a detailed business. You've got to really understand it. The other issue they had, man, was that their model of access is not affordable with the way the NHS is funded. And the reason we know that to be true is because now that they're funded, their share price obviously, unfortunately, has gone down massively. They're not, their list size is going down now, So they look at their list size has gone down. They've given up their Birmingham, and this is what happens because it's not a sustainable model. You can run it for a year or two, but it doesn't run. The third thing, man, is that the technology that they developed fundamentally was flawed. I was never a fan of it. I tried it, when it first came out, like everybody else. It didn't really work. You had to answer 45 questions to arrive at the fact that you had a runny nose from hay. All right. All of those models, none of them are very effective at the moment. They will be. I'm sure they will be when, with ChatGPT, we can see the power of AI. And I'm sure in future there'll be models, but that just was too early. people talk about vaporware and some of the demos weren't really true.
Yeah.
The GP fraternity didn't like them at all, which probably didn't help. But anyway, that's neither here nor there. But I think that the point is, man, funding in the NHS is very, very tight. To then run a service and to make it successful, and to run it at a sustainable profit. Let's talk about the word profit, because one of the big flaks was a private organization makes profit. It's important to understand, man, no GP will run a GP surgery if he's not making any money, because how's he going to pay his mortgage at the end of the month? A partner is profit. They have to make some money. No one runs it at a loss. So you have to make some profit. So this was the issue with Babylon, man. One was flawed technology, for sure, in my opinion. Clinically, there were lots of criticism. I don't know if you're aware, but huge criticism of the technology. It didn't really reduce demand, which is what it's supposed to do. And the model of care where you're slicing and dicing a small segment of the population, it doesn't answer the problems. So I would come back and say, obviously your podcast goes out to founders. If you're working on a problem, make sure you're working on a problem that actually is a real life problem. Fix a problem that exists, because there are lots of hard problems in the world that exist. And, without sounding holier than thou, we were always trying to do that. We were always trying to fix real problems. People talk about product market fit. You can call it that if you like. What real problems you're trying to solve? I'll tell you what they are: is access to healthcare, is unit cost of healthcare. They are still, and workforce. They are still the three biggest problems that nobody has solved.
Absolutely.
Hasn't got near solved.
No, thank you for sharing that. And I think it is important. And I think that's a nice way to kind of tie the conversation, solve a genuine problem. And there are lots of it in the NHS, in the current system, let alone the healthcare as a wider thing across the world. Any advice to founders, to people that maybe wanted to bring innovative solutions, the health tech app platform into the system? Because in a way, you would be the buyer, right? When people are approaching it, I'm sure you had it.
Yeah.
I think it would be interesting to see what you want to see before you go ahead and roll it out across practices.
Man, a little bit is a repetition of what I said. The problem we saw is that, and one of the reasons why we set up our own technology company is because no one had solved the two problems we wanted to solve properly. So we had to then solve it ourselves, yeah? The other issue is that there's a lot of people that develop tech, and then they try to retrofit it. They try to retrofit it into a problem rather than working organically upwards. And sometimes you get lucky, but mostly you don't.
Yeah.
The third thing I'd also say, man, is, NHS penetration with technology is a nightmare. Yeah. The market is extremely difficult to penetrate because it's fragmented. So let's say you've got a great product. You take it to one ICB. That ICB now says, oh, I'm not sure, take it to the PCN. Now, there are like PCNs for, how many, you have to like micro sell to PCNs. Each PCN has a board. That board has to meet. You're now trying to convince 7 people who have got another day job that they should buy your technology. So it becomes very, very difficult to develop a solution for the NHS, which the NHS will then take on en masse, or that you can sell en masse, because it's become so fragmented. And that's a big problem with the current reforms, where they sit. It's very hard to get a product in. Even for us, so we, for example, have a product called Easy Analytics, which I mentioned earlier kind of really helps us in our business. We've sold that to like a large CCG, if you like. So that's like 400,000 patient size. Great. That's good. Easy to do. Now imagine you have to sell that to a population of 30 to 50,000 times. Imagine the effort required to sell it to one of those. As a founder, how much money are you going to spend on marketing, and the return on that? Everybody wants a deal. The funding isn't quite clear. It becomes difficult. So I would say be very, very careful about developing something. I mean, your product is completely different. Yours is an incredible thing, but specifically NHS related stuff, man, I would be wary. Like if I was developing something new, I'd be wary about developing it for the NHS.
Yeah, definitely. I mean, like a lot of these groups with like prominent health tech founders in the UK, and a lot of the discussion from the VCs and the people that are backing them is very quickly find a way to enter the US market or other healthcare systems. Do not rely on the single payer being the NHS, because they can pull the plug overnight, even if you did get a nationwide contract. So no, definitely, it's a very interesting space. At the same time, the way Alex sees it means there's a lot of opportunity, right? No, it's been a jam-packed episode, Hasnain. Thank you for sharing the story. I was trying to look, there isn't much information about your journey, the stuff you guys have did, which is incredible. I do agree with some of the things we did discuss. But it's an absolute pleasure, and I hope to kind of see you continue smashing it.
Absolutely.
Thanks, man. Appreciate your kind words, and also you guys. I've looked into what you guys done. I think it's amazing. And keep working hard, keep going. You'll get there in the end. It's about the right mindset. And well done on the podcast as well.
No, thank you so much.